All right. I think in the interest of time, we'll go ahead and get started. We're already running a little bit behind. We'll try to make time during the journey, as the airline pilots say along the way here, get back on track. So as people trickle back in, I'll go ahead and get started. What I'd like to talk to you about this afternoon is something that we frequently encounter at our center, particularly given the number of liver and kidney transplants that occur. And I admittedly don't have a lot of new information to provide to you, other than recognition that this is a longstanding, challenging clinical population, and that being patients who are uh, identified to have pulmonary hypertension in the context of either CKD, but particularly end-stage renal disease, undergoing evaluation for renal transplantation, and patients with end-stage liver disease and portopulmonary hypertension. So these are my disclosures. All right, so what I'd like to discuss is the incidence, etiology, and pathophysiology, and then how do we diagnose pulmonary hypertension in the setting of end-stage renal disease specifically. We won't focus too much on chronic kidney disease before stage 5 end-stage renal disease, as well as discuss what are some of the potential treatment options. A hint, there aren't many, but what are some of the renal transplant specific considerations as well in this population? Similarly, talk about the incidence, etiology, and pathophysiology of portal pulmonary hypertension and how we diagnose and treat that entity, and what are some of the considerations around hepatic transplantation for those patients. So to start off with, let's talk about end-stage renal disease and kidney transplantation. So this has been shown already today a few times. This is the current 5-group classification of pulmonary hypertension. And if we look at patients with chronic renal failure with or without hemodialysis, they fall in this group 5, multifactorial with unclear mechanisms. But there's a lot of other comorbid disease that occurs in these patients that's also relevant, including heart failure with preserved ejection fraction or even reduced ejection fraction in some instances, which would technically be group 2 pulmonary hypertension, as well as sleep disordered breathing and hypoventilation syndromes, which is group 3 pulmonary hypertension. So it's messy, needless to say. And a lot of this, as many of you know, is driven by the presence of AV fistula in patients with end-stage renal disease who are receiving hemodialysis therapy. And these are just some of the effects of the arteriovenous fistula, including increase in cardiac output, decreased peripheral resistance, increased sympathetic activity, and myocardial contractility, heart rate, and stroke volume, as well as overall increased blood volume with increased natriuretic peptides and left ventricular size and end diastolic dimension, and of course, increased pulmonary blood flow and pressure, which is really the large driver of pulmonary hypertension in these patients. Some other pathophysiologic considerations, as I mentioned, diastolic dysfunction, which is often seen in the context of systemic hypertension, which leads to elevated left ventricular filling pressures and passive hydrostatic elevation of the pulmonary artery pressures as well. We talked about the arteriovenous fistula and some of its effects. Also, dialysis membranes, particularly cellulose dialysis membranes, are thought to cause neutrophil activation and sequestration within the pulmonary microvasculature, which is thought to contribute to pulmonary hypertension as well. There's thought to be some endothelial dysfunction that occurs in these patients. Decreased nitric oxide levels have been identified in patients on hemodialysis relative to those with no pulmonary hypertension. Also, increased endothelin levels have been identified in patients with chronic kidney disease, as have other substances such as ADMA, which is an inhibitor of nitric oxide synthase. It's recognized that arterial stiffening occurs in CKD, likely due in part to calcium deposition in the vasculature, including pulmonary arteries of CKD patients. And then I mentioned sleep apnea, which is a significant comorbidity in a number of these patients, which is often driven by volume overload and also contributes to volume overload when left untreated. Anemia seen in the context of these patients with decreased oxygen carrying capacity, and then it also further drives the high cardiac output state that we see in patients with AV fistula. And then there are systemic diseases for which renal failure and pulmonary hypertension are features that can also cause more of a group 1 or pre-capillary sort of pulmonary hypertension phenotype, particularly our connective tissue disease population, which we've heard a lot about this morning. And this is just a pictorial representation, as patients sort of progress through the stages of chronic kidney disease and ultimately dialysis, some of the factors and vasoreactive substances and molecules that have been identified to contribute to the development of progressively worsening pulmonary hypertension, which in some instances ends up with a hemodynamic profile with high pulmonary vascular resistance, in some instances, normal or decreased cardiac output, depending on the duration of the disease. So, right heart catheterization is really important to properly characterize these patients. As we know, it's a very low morbidity and mortality procedure, which has been proven in a number of series and analyses, but it's really critical to get that measurement of cardiac output and left ventricular filling pressure as measured via surrogate pulmonary capillary wedge pressure in most instances. Best to perform as close to the completion of a dialysis session as possible when the patient is volume optimized. Sometimes we can perform occlusion of the AV fistula, particularly if high cardiac output is noted during the right heart catheterization, and demonstrate significant reduction in cardiac output down to more normal levels, as well as reductions in intracardiac pressures, confirming the fistula's role. I will admit we do not do this routinely and usually presume that with the right hemodynamic profile and clinical context that a very elevated cardiac output in a patient with an AV fistula is attributable to the fistula. There is some risk of thrombosing the fistula, although it is small when this maneuver is done, so should be done with some caution. So, what is the treatment then for these patients with pulmonary hypertension and chronic kidney disease or end-stage renal disease? Well, optimization of all of the other comorbid contributors is really of paramount importance. So, optimizing systemic blood pressure control, medical management of diastolic heart failure, which we've heard about ad nauseum today, optimizing volume status, which oftentimes when we do right heart cath on these patients, we find, oh, well, your wedge is 27, and it turns out you need more intensification of your dialysis and volume removal with your dialysis sessions or additional dialysis sessions. Obviously, limitation of sodium intake and other factors which contribute to a volume overloaded state, and treatment of sleep disordered breathing with positive airway pressure therapy to make sure that any contribution from that is optimized as well. What are some considerations with regards to the fistula itself? Because I've told you that it is often a significant contributor, likely due to high flow. Although we do see in some patients, particularly those who may have undergone renal transplantation and have maintained a fistula for many years after, they've developed progressive pulmonary hypertension. Their cardiac output has become normal or even reduced, and their pulmonary vascular resistance has started to increase significantly. But before you get to that point, if you can identify a high output state attributable to the fistula, sometimes there can be surgical revision, or as I mentioned in the situation of a post-renal transplant patient, reversal of the fistula would be appropriate. Sometimes you can do Doppler flow evaluation of the fistula, and then your nephrology colleagues can help to determine if some revision of the fistula is possible. So when do we think about a real significant precapillary PAH component in these patients? Well, as I alluded to earlier, if you see persistence of a real precapillary PAH hemodynamic profile persisting despite optimization of all of these other comorbid factors that I've mentioned to you, particularly in a patient who's persistently dyspneic and symptomatic, um, then you start to wonder, has real intrinsic pulmonary vascular modeling occurred? And would this be someone who you could potentially trial a PAH therapy in? Um, and then, of course, there are comorbidities that might invoke the likelihood of precapillary PAH being a real contributor, such as connective tissue disease. But this is really best done in an expert center because we really have no good data on the application of pulmonary arterial hypertension therapeutics in these patients. And really, the multifactorial nature of these patients' presentation makes using these therapies challenging due to the potential increased volume loading on a stiff left ventricle and precipitating pulmonary edema. And then, sometimes these agents, particularly PDE5 inhibitors and riociguat, can lead to problems with systemic hypotension during hemodialysis sessions as well. So it's really important that a very thorough workup be done and treatment of all comorbidities be done, and these patients really be seen in an expert center to mitigate and minimize the potential misuse of PH therapies. So this largely just restates everything I've told you. So I think for the sake of time, I'll go ahead and move on to the next section of the talk, which is focusing on portopulmonary hypertension. So I'll start off with a patient case and take a show of hands. So this is a 55-year-old male with hepatitis C cirrhosis undergoing liver transplant evaluation. He has known portal hypertension. Screening echocardiography showed a TR jet velocity of 3.5, which then appropriately prompted a right heart catheterization showing the following hemodynamic profile, notably a cardiac output of 4.7 liters per minute, a PVR of 7.4 Wood units. So I'll just take a show of hands and say which of the following statements are true. A, this hemodynamic profile means the patient is at acceptable risk for liver transplant surgery. Any takers on that? Okay, good. B, the cardiac output and cardiac index are reassuring. Okay. C, parenteral prostacyclin therapy is warranted to improve risk profile for liver transplant. All right, good. And then D, dual upfront oral combination therapy with ERA, PDE5, or ST stimulator therapy should be initiated. Okay. So I think there's some room for debate in this. I think the traditional practice had always been to be as aggressive as possible to try to quickly control hemodynamics, never knowing how quickly liver disease might decompensate, and the patient may need to be in a situation where they're hemodynamically optimized for a liver transplant. But you could make the argument um, the one thing that concerns me about this patient is the quote unquote normal cardiac output, whereas a cirrhotic patient, their physiology should be one of a higher cardiac output. So this would suggest to me that the right ventricle is really struggling. But I think if liver transplant is not imminent, MELD scores are lower, certainly an approach utilizing dual oral therapy could also be appropriate. So within the classification of pulmonary hypertension, portopulmonary hypertension falls under group 1. We think of it as being somewhat histopathologically similar to other group 1 diagnoses. Um, and the hemodynamic criteria are the same to define it. There are, as I mentioned, what is thought to be similar to other group 1 PAH etiologies include identification of reduced expression of prostacyclin synthase in the pulmonary arteries. And we know that patients with portopulmonary hypertension and refractory ascites have higher levels of endothelin 1 than those without portopulmonary hypertension. Other proposed unique pathophysiologies in portopulmonary hypertension include decreased clearance of endothelin 1 by the diseased liver, as well as the overall hyperdynamic circulatory state of cirrhosis, which I alluded to, leading to chronic exposure of the pulmonary circulation to shear forces, leading to pulmonary vascular remodeling in a progressive manner. Other genetic variants of aromatase and estrogen receptor are also associated with the risk of portopulmonary hypertension, as well as other single nucleotide polymorphisms in genes encoding for PDE5 and NADPH oxidase are associated with an increased risk of portopulmonary hypertension. So what is the epidemiology? So we know that roughly 5% of patients with portal hypertension will develop portopulmonary hypertension, and that the severity of liver disease and or the portal hypertension for that matter does not necessarily predict the presence or risk of the development of portopulmonary hypertension. Female gender and autoimmune hepatitis have been identified as independent risk factors for the development of portopulmonary hypertension. Interestingly, patients with hepatitis C infection are less likely to develop portopulmonary hypertension. And these patients generally present with less severe hemodynamics compared to other forms of PAH. And interestingly, on the average, seem to respond much more robustly and dramatically hemodynamically compared to other group 1 PAH etiologies. So when we think about the hemodynamic diagnosis and risk stratification of these patients, this is data from the Mayo Clinic group, which has done a lot of work in evaluating liver transplant risk based on hemodynamics. And it really all boils down to mean pulmonary artery pressures and pulmonary vascular resistance, right? So if you're mean pulmonary, I just want to point out two particular groups that are at high risk of perioperative mortality when liver transplantation is being considered. So those with a mean PA pressure between 35 and 50 and a PVR of greater than 3 Woods units, as well as generally patients with a mean PA pressure of greater than 50 in general have an exceedingly high perioperative mortality, but particularly if the pulmonary vascular resistance is greater than 3 Wood units. So in 2021, the OPTN updated its criteria to as to what's allowed hemodynamically for patients to proceed with liver transplantation, and what they identified as two potential targets hemodynamically. One being a mean pulmonary artery pressure of less than 35, with a PVR of less than 5 Wood units, or a mean PA pressure between 35 and 44, with a pulmonary vascular resistance of less than 3 Wood units. There are the possibility to gain MELD exception points, so higher MELD scores on account of the presence of adequately treated portopulmonary hypertension. So, if you have a patient with moderate to severe portopulmonary hypertension confirmed by right heart cath, and a mean PA of greater than 35 or 35 or greater, a PVR of 3 or greater, and a wedge of less than 15. If PAH specific therapy is initiated and improvement is documented such that either your mean PA pressure is less than 35 and PVR is less than 5, or your mean PA is between 35 and 45 and PVR less than 3, you can gain MELD exception points. And this must be updated every 3 months, so there has to be continuous hemodynamic reassessment and proof of control of the disease. It is important to note, though, that portopulmonary hypertension alone in itself is not actually an indication for liver transplantation, right? So if patient has well-controlled portopulmonary hypertension, and their liver disease is not such that they would need or have a high MELD score and need imminent liver transplantation, can proceed with just treating the portopulmonary hypertension and not need to pursue liver transplant. So what we're concerned about in the peri and intraoperative period of liver transplantation in these patients is really what happens when the IVC is unclamped after the new liver is engrafted. This leads to a sudden and robust volume loading on the right ventricle. So you can imagine, if your RV afterload and PVR is high, that the ability to tolerate that is going to be poor, and this can lead to cardiac arrest in the OR. So, appropriate pre-procedural precautions should be taken, ideally involving cardiovascular and or liver transplant specific anesthesiology team, consideration of intraoperative placement of right heart catheter, and then appropriate precautions and choice of drugs for anesthesia induction as well. So what do we know about outcomes after liver transplantation? Well, some patients are able to partially or completely wean off of PAH therapies after transplant. However, we don't really know if this negatively affects longer term outcomes in terms of pulmonary hypertension and pulmonary hemodynamics. There was a study out of the French group looking at 35 patients that were followed to a median of a little over 3 years after a liver transplant. Um, and what they showed was 27 survived beyond 6 months after the transplant. IV prostacyclin was able to be weaned off. In 20 of them, there was continuation of ERA and PDE5 inhibitor therapy. And at the last evaluation, 20 of the 27 patients had a mean PA pressure of less than 35, and 8 of them actually had a mean PA of less than 25. And the overall survival estimates, you can see there, were 80%, 77, and 77% at 6 months, 1 year, and 3 years. It is important, though, to be sure that pulmonary hypertension is resolved soundly and continues to be treated if it's still present after transplant, because the congestion of the new liver graft can lead to rejection. So we want to keep pulmonary hypertension well controlled. Now, we sometimes see this phenomenon of quote unquote new diagnoses in the immediate post transplant period, which I suspect were probably just patients who actually had portopulmonary hypertension all along, but the echocardiographic findings were not significant enough to lead to suspicion to perform a right heart catheterization and prove it pre-transplant. So what is our evidence base for PAH specific therapy in these patients? I'm just going to briefly point out that in the REVEAL registry, which was a very large US-based registry of PAH patients, they enrolled 178 patients with portopulmonary hypertension. And in general, their outcomes were poorer compared to patients with group 1 idiopathic or familial PAH. However, the data on the use of PAH therapy for these patients is really limited to mostly uncontrolled studies, case series, and case reports, though they're not typically included in many of our registration trials for PAH therapeutics. We're not going to go over this in detail, but just to show you, amongst the prostacyclin analogs, PD5 inhibitors, and SGC stimulators, as well as endothelin receptor antagonists, we're largely looking at, case series, case studies, retrospective analyses, uncontrolled data. However, we do have one randomized controlled trial called the Portico trial looking at the use of macitentan in these patients. This was a phase 4, 12-week double-blind randomized trial of macitentan 10 milligrams versus placebo, followed by a 12-week open label period. And what was observed, the primary endpoint of change in pulmonary vascular resistance at week 12, was that there was a 35% reduction observed in PVR compared to the placebo group. So in conclusion, we can say that the pathophysiology of this entity is not fully understood, but that their outcomes are generally poorer compared to other PAH etiologies. Screening echocardiography is imperative, particularly for those undergoing liver transplantation, and right heart catheterization is necessary when echocardiogram suggests at least moderate pH or higher, generally thought to be a TR jet of around 3 to 3.5 meters per second or higher. Treatment of this disease is necessary regardless of the intention to do liver transplantation. And overall, the optimal goal in terms of hemodynamics is to get the mean PA pressure less than 35 with a preserved cardiac output. And with that, in the sake of time, I will close, and perhaps we'll go ahead on to our next talk, and then there's a little bit of time at the end we can field some questions related to my talk or the next.